Hello, everybody. Today we have a great discussion around the implant industry as a whole. What we're going to go over today is a whole set of topics with a specific conversation. Dr. Randy Resnik has joined us. We're going to talk about who he is, his impact on this industry, the Resnik Institute, and the education that provides. But we're also going to get into cover all things throughout, not just implant education, but implants in the dental implant industry itself, the future, where this industry is going, a little bit of where it's been, but most importantly, where it is today and where it's, the future of the implant industry, and how dentists can approach this, incorporate it in a safe way, where dentists commonly get into trouble, the rise of litigation in the dental implant world, complications, how to navigate them, what's best for patients, all these types of topics. So first, I'm going to introduce Dr. Randy Resnik. Randy, thank you for joining us today. I'm really excited to have you on the podcast, on the discussion, and we're going to be talking about the Resnik Institute and specifically a virtual program that I know you're launching for a lot of CE Zoom members and other individuals as well.
Thanks for having me, Andrew. It's great. I love to talk. This is my favorite subject, so let's go to it.
Awesome. So let's kick it off with a little bit of just allowing everybody to get to know you a little bit better. So Randy, you have been in the implant world really since its inception, but can you give individuals a little bit of understanding of how you started your implant specialty education and where implants were at the time? And I know there's three specific things I'd like to understand: the prosthodontic side, the surgical side, and even the radiology side, and the different levels of experience you have in those.
Great, yeah. So I went into dentistry. I was a second-generation prosthodontist. My father was a pioneering prosthodontist and fixed prosthetics for over 40 years. And I went to the University of Pittsburgh Dental School. And in my residency, I went into prosthetics. In my residency, there was a gentleman by name of Dr. Carl Misch, who happened to also be a prosthodontic resident at the same time. And he is one of the true pioneers in implantology. So I was fortunate enough to be with him at that time. After prosthetics, I went through a implant fellowship where it was mainly surgical oriented. So not only was I able to learn the prosthetic aspect of implantology, but I was also able to learn the surgical aspect of it. After that, I went on and received a master's degree in radiology, so specifically in CT scans. So if you go back, this is over 35 years ago. So CT scans were basically just used in the medical field, almost never used in the dental field. So I was very fortunate. I always say I was at the right place at the right time. Since that time, I have been teaching implantology. Most of the time with Dr. Carl Misch, but since his passing over 10 years ago, we have taken the educational process to what we call now the Resnik Implant Institute.
So Randy, you started getting right into education. A lot of it is your education. I'm going to talk a little bit from my personal experience. I initially felt I had a decent foundation. I did a GPR and we did, call it a dozen implants for each resident. And I felt decent about it, but knew I needed more education. I was passionate about it early out of my residency program, starting my career in dentistry. Looking online, and it was a bit tough for you as a new dentist, or for me as a new dentist, but anybody I think struggles with the same thing, and I hear it a lot. You have a lot of noise on implant education. You have vendors putting on their programs. This, company, whether it's Noble BioCare, Zimmer, Lifetime, LifeCore, there was all these different programs coming out and saying, hey, buy our implants, we'll send you for free to our implant institute or to our educational centers. And okay, that sounds good. Is that going to be enough? Am I going to be prepared? And you kind of go to those, you get some confidence, they do it really well. There's a lot of glamour around it, and you're starting to feel energized. You have your equipment set up. So that's kind of the vendor side. But separate from that, there's all this like marketing and so many different institutes. And I picked one. It was a decent price point, 9 different weekend programs, 18 days in totality, a couple hundred hours of CE education. Felt good. I went into it, and initially you're getting jazzed, you're feeling that confidence, you go back. I also flew to this location. I took it in Chicago, but this particular implant institute was all over in different cities, launching in different ways. And I felt it was a bit disjointed. You would go and you'd get something from a podium speaker. They would be passionate and very, methodical about what they told you. And then the next day you'd have somebody and you'd realize they're conflicting each other. And sometimes, calling it out that they're in conflict to who we just heard. So you're getting whipsawed back and forth on these different messages. You don't feel like you have a continuity of thought with it. So fortunately, I got to go to a study club. You happened to be the speaker at it. Again, right place, right time. I happened to live in Western Pennsylvania. You were practicing in the Pittsburgh area. So I had the luck and fortune of being able to see you in a general study club one night. Got introduced to what you were speaking about. You were part of the Mish Institute at the time, the surgical director, and it just felt right to participate in it and to attend the Mish Institute. And that was its own continuum and very involved. And after having completed that, I realized how much I didn't know, even though I had already had several hundred hours of implant CE under my belt. So what I'm wanting to talk a little bit and getting people to experience is not just a promotion of the Resnik Institute and what you do, but kind of talk to implant education as a whole. All of this noise that's out there, what should individuals be thinking about? How do you make sense of it all? And what are the watch outs that people need to be looking at? Because that was my experiences. I ended up investing a lot of time, money, and unfortunately, I got to the end of that and realized after I completed your continuum and Dr. Carl Mish's program that I was doing a lot of things wrong, and very lucky that I didn't create a serious complication for a patient.
Yeah, so as I said, I was very fortunate to really have a very strong relationship with Carl Mish. The one thing that he taught me, and I learned this through the residencies I went through also, was scientific-based curriculum. So everything that we teach in the past at the Mish Institute, now at the Resnik Institute, it is scientific-based, meaning we look at the studies, and we just don't look at like one study where for instance, let's talk about splinting implants. Should you splint implants? You can find an article that says yes. You can find an article that says no. What we look at is what's called systemic reviews and meta-analysis. And these are studies that take all the studies and they put them together. They take the bad ones out, and then they come up with a conclusion. So that is scientific based. Plus, we add on the years of experience. So we've tried everything. We know what doesn't work. Why the complication book, and it's one of our most popular classes that we give, is because doctors have a complication and they might not have learned this. Most likely they didn't learn in dental school. If they took a weekend course, they probably didn't learn it. And now they have a problem and they have to find a solution to it. Now, it's a lot different. Problems back 30 years ago, the way that we looked at success was if the implant integrated with the bone. Basically, we put the implant in, let it heal 4 to 6 months. If it was strong in the bone, that's a success. However, now that is not the only factor when evaluating success. One of the biggest factors now is aesthetics. something that we never thought about in the past. Most patients back in the early days of implantology were just happy to get a tooth. So it didn't matter how it was positioned or maybe what it looked like. They wanted function. Now, patients prefer and also most demand perfection in the aesthetics. So that means that you have to have that implant in the ideal position. You have to have that the bone tissue in the right position. And you have to have the ideal soft tissue drape around the implant. So, Andrew, when you're talking about other institutes and weekend courses, the problem that I see out there, especially in the legal arena, is doctors that do take these weekend courses, and then they get into these cases that are highly aesthetically demanding, and now they're in over their head, and it's a real problem. Because to fix these implant complications is not easy. A lot of times you need specialists. Sometimes you can't even fix them. So it's very, very difficult. So if I would say, when you're looking for an education, you want to look for something that is scientific based, basically just not your opinion. Now, Andrew, you've heard me lecture enough that you know that I've almost never, ever shown you one of my perfect cases. I'll always show the ones that I screwed up or someone else had a problem with. The reason is I don't want anyone ever to have to go through a complication like this, and we'll talk more about this later in the interview, but the medical legal aspect of implantology and also other aspects of dentistry is really important that a lot of people don't understand until it's too late, until they're in the middle of a problem. So to answer your question, I would say you look for certainly not a weekend course. Manufacturer courses just give you the generic overview. You look for one that is scientific based and also that has strict protocols and techniques, and it's generic for any system. So you should be able to go to an educational curriculum and not just learn one specific implant type or technique.
You hit a specific point that I experienced. One, real situations. Things don't, even in the best of circumstances, always work. So I'm going to speak about my particular journey in implants. I was overconfident from some of the education that I came out with. There was a lot of promotions of immediate implants for some of the early education that I had. So as a young doctor, feeling like I've invested the time, the money, immediate seemed like the way to go. Your education really created a progression. Don't do your first implants in the aesthetic zone. Tooth number 8 might be easy to get to, but it doesn't necessarily make it easy to do. And I placed a immediate implant in the tooth 8 position. And you may recall this because you helped me.
I do remember this. I do remember this.
So I took the tooth out, atraumatically, placed the implant immediately, and I restored it immediately. I put an abutment, I temporized it. I don't believe it was in, full load, but of course, once you put a crown on it, there's load, right? There's forces occurring. First post-op, 2 weeks later, everything looked good. Patient's happy. I'm excited. Patient happened to slip and fall, of course, bumps the implant. Whether it was just related to that or it was already having complications, I'm not sure. But came back, and this implant is out of his mouth completely. Brings it in. Redoing that case is not a matter of, okay, let's put a new implant in there. And even a little bit of that, like tongue-in-cheek, yeah, manufacturers might give you a free implant if one fails. They might send it to you as if, okay, that solves the problem. This became such a challenge to maintain the patient's aesthetics. You helped me to graft this area, a lot of granulation tissue starts to enter in. It just becomes such a challenging, complex complication to navigate. And being honest about it, not having any, shaming, these things happen. But I come back to, there's a lot of that promotion. Immediate, faster, quicker, cheaper, better, whatever it might be, is always the drive. And that's when you don't understand all the different factors going on. You talked about complications. You wrote a textbook on complications. We're going to get into your textbooks in a second. But your experience in the area of complications, specifically when they become legal. Talk to us a little bit about what you're seeing in the medical legal situation that dentists go to, specifically in the implant world.
Okay, so I call it, basically it's a hobby that I started over 30 years ago. I do a lot of expert witness work, mainly defending dentists all over the country in malpractice suits. And it's taught me a lot. It's made me a better educator, and it's made me a better clinician because I see where people are having problems. So just right off the bat, Andrew, you talked about, feeling overconfident. And a lot of people, what I see in the medical legal field is a lot of doctors early on in their career, they take a course and they go out and they do a number 8. Or I think, which is even more difficult, is a number 30 or 31. So what we teach is something completely different, where the first implant I want you to do is going to be an upper bicuspid, preferably the first bicuspid. Why? It's basically out of the aesthetic zone. There's no nerves to worry about. You always are anterior to the sinus, posterior to the nasal cavity. There's always a lot of host bone. Access is very easy. You can look straight in, and there's very little worries with that site. So that's where we have our doctors start. But a lot of people...
Not an immediate implant on tooth number 8.
Not an immediate implant on tooth number 8.
If you look at immediate loading.
Yeah. If you look at our curriculum, we have 5 courses. The immediate placement, immediate load is the last course, and it's what we call S5. The reason is it's the most difficult. But let me go back to why the first bicuspid maxillary is what I want people to start at, because then you will have a positive experience. Some people will say, and they'll send me an x-ray, this is my first case, it'll be number 30 or 31. Now, access is very difficult. You're usually within millimeters of a neurovascular bundle that can basically ruin your career if you interfere with the nerve conduction on that nerve or enter that canal. You have the aesthetic zone, which you already said, Andrew, but what I see a lot of is doctors who want to do an all-on-4 for their first case. Oh, it's only 4 implants. And you said something very interesting, Andrew, when you said about, the implant, they fail. And manufacturers, almost every manufacturer will give you a new implant. So from a surgical standpoint...
That solves the problem.
It's easy. I put an implant in and it fails. I send it back to the manufacturer. They give me another one. It takes only my time to put another implant in. Now let's look at an all-on-4 case. So you put 4 implants in. Everything's good. You restore it. One of the implants goes bad. Now what happens? You lose the prosthesis. You have to take the prosthesis off, place another implant in. The prosthesis isn't going to fit anymore, so now you have to make a new prosthesis. So let's say it's a monolithic zirconia. Well, if that's the case, now you have to have that lab make a whole new prosthesis. Most labs are going to charge you just like they did the first time. So now you're looking at a $3, $4, $5,000 bill. So the complications is something people have to take into consideration, and it's where you start. The reason why that we track all of our doctors, what they're doing, placing implants, doing bone grafts, even their financially, what it's the impact it's had on their practice. And doing it this way, a tiered educational approach, where you start out with the basics, extracting a tooth atraumatically, socket grafting, then doing single implants that are in ideal positions, then going to multiple implants, then maybe go to full arch implants. And that has worked for us, and that's why we've been so successful over the years.
So in my particular example that we talked about before, the cost that I incurred to redo this case had very little to do with getting a new implant. That's kind of that tip of the iceberg. The first procedure, okay, removal of the implant. Then I was fortunate to have you in town nearby. You were able to come assist me on something that I wasn't able to do yet, which was graft, do effectively a guided bone regeneration, a full block graft of this area. Again, in the aesthetic zone, so being very particular about incision lines, etc. Didn't charge the patient for this, maybe had the opportunity to, and that's a debate in itself is, okay, if a complication occurs, should you redo this for free? Yes or no? Whose fault is it? Aside from all of that, I'm early in my career. I'm not looking to have that conversation with the patient. So we graft it, then place a new implant, and then finally restore it. Of course, it takes about a year long. The patient thought he had an immediate. Why has this got to slow down now? End of the day, it just creates, and fortunately, we were able to do it. And we had a successful case. And that implant, I saw that patient not long ago, still healthy, still aesthetic, like everything. And this is, let's think through this. This was probably 2008 when I did this case.
Okay.
So
I was going to say about 15 years.
15 years ago. So in all, rights, it's a success, but a recovery that cost me a lot of money, stress, sleepless nights, and fortunately had an understanding patient that kind of walked through it. Some patients will leave, get frustrated, talk poorly about the doctor, potentially sue the doctor. And you've experienced a lot of these. We've had conversations of some of the dentists that you've attempted to defend. Some of them, you've talked to me about cases that have had massive medical complications from an implant gone bad, infections, nerve damages. You talked about tooth number 30. Yeah, the neurovascular bundle's right there. I remember the first time I placed a 30 without, again, before I was taking cone beams, because one of the educators I went to said, you only need cone beam if you're doing an implant in, near the sinus, or if your pan shows that you don't have at least 12 millimeters of bone in 230. Okay, well, it looked like the nerve wasn't an issue for 230. I didn't take a cone beam, placed my first osteotomy drill. I ended up sinking, and then I'm seeing all this bleeding going on, and didn't realize it at the time, but later came to understand that there's a lingual concavity there that I went right through, because in this person's first molar, that lingual concavity came all the way anterior beyond 230. So you've seen it all. Talk about some of those, kind of scary complications that you see dentists, maybe the frequent flyer lawsuits that you see that have really gone bad.
Yeah. So let me first address your case, because that's a very, very good case. And it's a good learning case for people because, number one, I've known you a long time. You're one of the most conscientious providers I've ever seen, and you were going to do the right thing no matter what. That was it. You were going to do what was right for the patient. But let's say if that patient ended up in someone else's office, and let's say that you were not proactive in this and explaining to the patient, they had to have this bone graft, and that bone resorption went and affected the other teeth. that would be a real problem, because now instead of one tooth you're worried about, now you're dealing with 3 teeth. And I just had, you said give some examples. I just had a doctor that I defended out on the West Coast, and actually we had to settle this case. And I'll tell you why we had to settle it. It was a 19-year-old boy that had congenitally missing laterals. They took a CT scan. Their local lab said, yes, you can squeeze an implant in. And they put an implant in, ended up restoring it, however, started to get bone loss. And the bone loss ended up affecting the adjacent teeth. So here's a 19-year-old that goes to another office. This doctor says, oh my gosh, we have to remove 3 teeth. Now you have this patient who is in college. Now they went in for the replacement of 1 tooth, and now they've lost 3 teeth, and now you have to replace 3 teeth. And that involves usually an onlay bone graft. So all because the technique, there were no parameters in place to prevent that practitioner from doing it. The lab told them they could do it. They went to a weekend course. They had very little experience. And why not? Let's do it. But the ramifications of that, and it was settled for a lot of money. And I mean, basically, rightfully so. This patient is basically has a nightmare when they're supposed to be going to college and etc. So let's talk about nerve damages. I've had every type of nerve damage you could ever imagine. And what people don't realize is, nerve damage, the mandibular nerve, the infraalveolar nerve, there's 3 different types. And what the reason why I said you don't want to do a 30 or 31 right off the bat is you have to determine what type of nerve it is. Type 1 will hug the roots of the teeth, meaning there's very little room to place an implant, where type 3 will be on the inferior border of the mandible, and you'll never get near the nerve. Type 2 is the most common. So a lot of people don't even talk about that. It's very rare that I ever hear anyone talk about what type of mandibular nerve it is before they're placing an implant in that area. If you go to the maxilla, in the posterior maxilla, if you look at all 3 of the textbooks, I have sections on migrating implants, where implants are put in, there's not enough bone to hold them in, they go up into the sinus, then they migrate into the ethmoid sinus, into the orbit, into the sphenoid sinus. I have multiple ones that have gone into the anterior cranial base, which is basically the brain. So you have to be very, very careful. And, when you asked that original question, how do you pick a educational curriculum? A lot of people don't even do that. They'll read a book, or they'll watch a video on YouTube. And a lot of patients now shop, and they look for people's credentials. So credentials have a lot to do with the patient accepting your treatment plan, but also medical legally. The first thing they're going to ask you when you're on the stand is what your experience and where you learned to do this, because most likely you didn't learn it in dental school. Because dental schools are there's so much to learn in dental school that the implant curriculum is very, very minimal. You went to a good GPR residency, which is great, but a lot of people go to GPRs and don't place any implants. So if we look at where implantology is going, back in the 90s, about 7% of general dentists placed implants. Now it's 30%. And if you look at Europe, over 90% of implants are placed by general dentists. So it is the general dentistry field, and rightfully so. I've been teaching dentists for 35 years, and general dentists have very good dexterity. They use that handpiece every day. It's just there are new protocols and techniques and what I call safeguards that have to be implemented because that is foreign to them. Most young practitioners, especially just coming out of school. So you have to be very careful and understand. And that's why when I go back and I say, Andrew, I've never shown one of my perfect cases. I don't want anyone to think that everything is perfect because there is really nothing that's perfect. You know, you can do the best job that you ever think is imaginable, and the patient might not like the aesthetics of it or the angle of it or whatever. So you have to know enough to inform the patient. And informed consent, what people, they get that wrong. They think it's a piece of paper that every patient has to sign. It's a verbal. So in every state in this country, you don't need a written consent. It can be verbal. Ideally, you do verbal and written, but you explain to the patient the possibilities of what can happen and the outcomes.
The journey is something that I think is essential. What I see as being a really important outcome is you need to get doctors to have these kind of warning signs going off in their head. And having hundreds of dentists that I was responsible for as I grew North American Dental Group and had, 400 plus doctors, getting them to look for the mentoring was one of the key things I looked for when we were hiring doctors. Are they wanting to learn? Second, do they have a sense of caution? If they don't have these early warning signs going off in their head, as you're talking to a patient, as you're assessing this case, and we're going to get into case planning and treatment planning in a little bit. But what I want doctors to have is, there's confidence on one side, there's naive on the other side. Sometimes those collide. What you want to have is this sense of not fear. You don't want to be to the point where you're paralyzed and you're so afraid to get into implant dentistry because it's something that can be it's a great procedure for patients. And a lot of it should be navigated, whether surgically or just prosthodontically, it should be navigated with the general dentist. Can be. So you don't want them afraid to the point where they avoid it altogether. But at the same time, you don't want them jumping in or a doctor jumping in, similar to myself, not knowing where you can run into significant issues. Now I think of the hundreds and hundreds and likely over 1,000 implants that I've placed successfully. I think the best thing that you learn as you become and go from being kind of a novice to somebody that has kind of what I'll call mature foundation in implants to sophisticated, not nearly to mastery, but as you grow along that kind of growth curve, and I talk to our doctors a lot about that journey, whether it's in restorative or in implants or in endo, it's getting to that sophistication. And at that, you're able to look at, okay, this case has this level of complications that I think are going to approach in how I'm going to tackle this case. Am I competent to be able to navigate it, or do I need a team with me? Do I need to refer part of this case out? Do I need to, or is this patient not indicated at all? This is too complex. They don't have the medical health that they need. They don't have the dental health that they need to approach this case. So it might not be indicated, or at least not indicated until we do A, B, and C. That's the kind of caution that I think is essential. So when we're talking about implant education and we've hit different curriculums, different institutes, I think it's just recognizing that it's a journey. First, a doctor needs to accept the fact dental schools are only going to get you to be able to learn so much, specifically in implant dentistry, but really in a lot of paradigms. And taking yourself to kind of acknowledge where you are. If I'm doing a review with a dentist, say they're 3 years into their career, I bring up different disciplines. Okay, let's start with restorative. Tell me where you believe you are in this level, in this spectrum. Do you feel like you have the foundation Do you feel like you're a mature restorative doctor with occlusal principles, etc.? Do you feel like you're sophisticated, or do you feel like you have an advanced mastery of restorative? And then let's get into endo, and let's talk about this with implants. And they'll do an assessment of where they believe they are, and then I'll do my own assessment and say, from chart reviews and from case planning and from hearing from your dental director, we believe there's disconnects in where you think you are here and where you think and where we think you are. In a good scenario, we assess them higher than where they assess themselves. But where it's a concern is where they assess themselves much higher than where their directors and their mentors assess them. That's where it's likely because those warning signs aren't there and they're overconfident compared to their competence. So in a journey, let's talk about what you believe the amount of effort, time, education, but not just education, but experience. We'll get into, I think the credentials start to come along with that. As you migrate from foundation to sophisticated, there's also opportunities to become a fellow in certain organizations, a diplomat, what's involved in those. So let's kind of shift towards, okay, I'm a implant dentist. I want to get from here to there. What do you see in that journey for a doctor?
Right off the bat, Andrew, you said it perfectly. A lot of doctors, they think that they have the foundation to do it, but the diagnosis and treatment planning is, they don't see what is the problem. So one thing that really helps is that every single case, we put it into one of four categories depending on the amount of available bone. We call it Division A, Division B, Division C, Division D. Real fast, Division A, plenty of bone, soft tissue. You can put an implant in and it's going to look ideal. Division B is where the ridge gets a lot thinner. So you don't have enough bone to put an implant in where you have to graft it. Division C is extensive atrophy and height or width. And then Division D is just almost no bone at all. So my recommendation is that most dentists start out in Division A. This way you'll never have a problem. Then once you get confident in doing those Division A cases, then you go to Division B. And you learn to bone graft and build the bone back to where it once was. Whether you ever tackle a Division C case or a D case, most likely you won't, which ideally you shouldn't anyway, because a lot of those patients aren't candidates. One thing that we have a problem in dentistry is that we believe that every patient is a candidate for implants. They're not. So I tell patients every day they're not candidates. Where I really see it in the medical legal arena is with medications or systemic diseases. I see so many cases where the doctor doesn't even read the medical history, doesn't even know what the drugs are. If we look at the complications book, the surgery book, or the new prosthetic book, the largest chapter out of all these books is the medical evaluation. First of all, you have to know if the patient is medically able to have this, or if the morbidity is so high that the benefit of placing an implant outweighs the risk, or does the risk outweigh the benefit? So you have to determine that. So with that being said, divisions of bone is one concept that we look at. Second is area of the mouth. As I said before, you know, the anterior, the aesthetic zone, some people may never want to even get involved in the aesthetic zone. And it's not only as the, I know a lot of this we're talking about the surgical aspect, it's also the restorative aspects of this. So I mentor a lot of restorative dentists. They don't do surgery at all. And the first thing I'll tell them is, you are responsible, wherever that implant's placed, you're responsible for it if you restore it. in most lawsuits that I see because of malpositioned implants, the surgical doctor and the restorative doctor gets sued. That's just the way it is. Never was that way in the past, but that's the way it is now. And unfortunately, it's only going to get worse. So with that being said, you have to have a foundation. And when Andrew first talked about at the beginning, where he went to a implant curriculum where there were different speakers, that's the problem with a lot of these programs where they have conflicting information, techniques, protocols, and now the doctor doesn't know what to do. So my recommendation is you understand basically one school of thought, and you don't need to be a hierodontist, okay? You don't need to be a hero. Patients will understand if you're not a candidate, if that patient's not a candidate. You just have to explain to them. They'll respect you more. But what they don't, even though you think that the patient is your best friend, they love you, they love your office. If something goes wrong and there's a complication, there is always ill will, and it never comes out positive. So you have to be very, very careful. So, Andrew, the other question you asked me is the journey. My recommendation is the tiered curriculum. You start at the basics, and even with socket grafting. If you would ask me, where do you see most complications now? I would say socket grafts. Do you know how many times I get a CBCT sent to me and they say, hey, I socket grafted this, there's no bone? Because a lot of doctors don't understand there are different types of sockets. Basically, if you lose that buccal plate, you have to treat that completely different than if you do have the buccal plate. It's not as easy as taking out the tooth and pushing bone in and calling it a day. Now it becomes into a bone regeneration, remodeling, and repair process, and it's very, very difficult. So once you start to do that, then you go into the single implants in the ideal positions, then the multiple and the full arch. And some people don't ever want to get into bone grafting. I believe that bone grafting is one of the most rewarding aspects of implant dentistry. To actually grow bone back to where it once was is amazing, and it's very easy. We have a cookbook, 8 steps. It doesn't matter where it's at, what type of patient it is, you just do, you can't skip a step. And I always give the analogy, it's like baking a cake. If you skip a step baking a cake, it's not going to come out right. Or if you substitute an ingredient, it's not going to come out right. And that's the same with bone grafting. So once you go through the tiered curriculum, you're going to get very proficient at doing implants. And then the credentialing, I believe, is very, very important in implant dentistry. Patients like to see that. Medical legally, it's important. We actually have a pathway that you start at the very beginning, and at the very end, you become board certified. Now, even though the implant dentistry is not an ADA recognized specialty, I do believe that in the future it will be. And there is one organization called the American Board of Oral Implantology that is, by most states in this country, you're allowed to call yourself board certified, and that is basically the only credentialing board available. So my goal is when I see a young student first time, they just come out of dental school, I want them to become board certified, and we have a pathway for that. But you can't skip steps. It takes time. It's a learning process, and it just doesn't happen overnight.
I really do appreciate the ABOI. The doctors is, I'm talking to them about, okay, let's get you there. Let's talk about your journey. You want to start with the end and what's it going to take for me to get to that. So if being a diplomate of the ABOI, which you're saying states allow you to then say you are board certified, or I believe some states have said, hey, you can call yourself an implant specialist if you have that credential. What's entailed in getting that credential? I went through this, and I still, I appreciated the challenge it was, because this was something that there's a certain number. You have to show that you've not just completed CE in implant dentistry. You have to show that you've done it through I don't know if accredited is the right term for this, but a recognized curriculum that they would approve. So one of the institutes has to be kind of a thoughtful progression of several, I think it was over 125 hours in a institute. I think that there was a minimum implants of over 100, but not just that they were completed, but that they showed post-operative success multiple years later. So you had to show the case at the beginning, and then the case restored, and then post-operative x-rays and photographs. And then not just in single implants, but across 10 different types of cases. And then there was an examination. And in addition to the examination, there was a verbal review that you had to go. And I remember walking in this room with a dozen different tables, and each table had 2 or 3 individuals, and they would challenge you on some of the cases that you submitted, as well as just different principles in implant dentistry. So the journey to defend those cases, to go through and complete the written examination, to complete a certain number of cases across, a full quadrant of implants, a full arch of implants, a sinus grafter and a sinus lift case, a socket preservation case, that all of those showing not just that you completed them, but that you show healthy implants in function, multiple years in health. So by definition, you can't get this credential overnight. You have to be thinking about the journey that you're going to take to be able to become the diplomat. And I believe you're one of the individuals that have helped on the examination side as well.
Definitely. So I believe that implantology will become a specialty, and most likely the ABOI will be grandfathered into that. So it should be a difficult, strict exam. It should not be a rubber stamp.
Right.
Before any of our doctors take the exam, we actually give them a similar exam. So they go through like a practical examination prior. So we evaluate their cases. We ask them the tough questions, and so that they know before they're going in. And I'm proud to say we've never had a doctor fail. And Andrew, it is a high failure rate. The written and the verbal, the oral exam has a rather high failure rate. But that's good. Again, this is a small fraternity. And I believe that when you take the exam, especially the written exam, now what's on that exam are questions that you should know if you want to call yourself an implant specialist.
Yeah.
And that's what we teach through our curriculum every single session, because there are basics similar to, you should know what the ideal A1C is for a diabetic to place an implant. You should just know that, okay? And those are the type of questions. So to answer your question, yes, it should be rigorous. And we do have a pathway that we've kind of built so that by the time you get through the end of our curriculum, the ABOI is a breeze, basically.
It was definitely one of the most rewarding moments when I learned that I had passed both the written and the verbal exam and was able to receive the diplomat and the ABOI. It was because it was a real challenge. And I remember being nervous, anxious, intimidated going into the verbal exam, and having those conversations, talking through cases, talking through complications. It's not, nobody in there is meant, you're not meant to go in there and brag up that you have nothing that you could have improved on any of the cases. In fact, that's where a lot of the conversations was tell us what you would do differently. And what do you, like, we see gaps in this case here, here, and here. Why did that occur? And of course, dovetailing into other science and understanding the medical aspects of the patient, a lot of the conversations were there, because you're not just presenting some photographs and x-rays, you have a full profile of this patient. You know, patient A, he or she presents with these conditions. What is it that you had to consider? All of that type of stuff. And you're right, to be able to speak to that, know that stuff, and then naturally you're going to have those abilities to assess the difficulty, the case difficulty assessment of a case as you're diagnosing and treatment planning. You talked about a textbook a couple times, so this is where I'm actually going to brag on you for just a bit. You talk about this person, there's the cliche, wrote the book, but you literally wrote the book. I know you co-wrote, some books with Dr. Carl Misch. You continue to write and update the textbooks, and I believe you just completed yet another version, an updated version, and pretty much an entire rewrite of the textbook. So talk about kind of the most recent textbooks that you have. I believe there's, of course, the Contemporary Implant Dentistry updated version that's coming out, Complications, Prosthodontics. Can you just tell our viewers a little bit about the textbooks that you have coming out and the ones that have just been released, and what's involved in putting that together?
Yeah, so the first textbook was Dr. Misch got sick in 2013, and I wanted to do something to say thank you for everything that he's done to our profession. So I wrote a complication book and dedicated it to him. And basically, it's almost 1,000 pages of anything that can go wrong, why it happens, how you manage it, and how to prevent it. And it talks everything from, a prosthetic porcelain fracture to a patient having a fatality in your office. So it encompasses everything, and that's been very rewarding because there really wasn't a complication book prior to that. After that, I rewrote the surgery book, which was written, which I helped Dr. Misch on over 20 years ago, and completely updated it. Probably the biggest addition to it is the digital component to it, because everything has changed. Especially digitally, we really incorporated that into the new surgery book. And we have newer techniques, protocols, materials. Everything that we teach is a generic material, such as if we're doing guided bone regeneration, there is a specific type of bone that we use. It's a mineralized allograft, freeze-dried allograft. No matter, you can buy it from any manufacturer, but we teach you how it heals. That's why you want to use that. And the same with implant systems. You can use any implant system. Here are the protocols and the techniques of doing it. The most recent one was the most difficult, and that is the prosthetic book. If you look in the literature, implants, most of the literature is more surgery based. Very little is prosthetic based, and the prosthetics change so much, the materials, the techniques. So this one is going to be the largest book. I just finished it last month. It's in production right now. It's approximately, yes, it's 48 chapters. And about 1,500 pages. So it's almost going to be double what some of the older books were. But it's going to encompass every aspect of the prosthetic and prosthetic principles that an implant dentist needs to know. And it's very comprehensive. And like I said, this was the biggest one, and it's finally over. So
that's awesome.
We'll be seeing that come out probably by the end of the year.
These textbooks are by far the most widely used textbooks in the implant world internationally. I was at a group in Switzerland and saw contemporary implant dentistry sitting on, the bookcase of a couple of the doctors. Dental schools are adopting it and using it for their cases. A lot of other institutes, actually, beyond the Resnik institutes, use this textbook or these textbooks as is kind of the foundation of what they go through. So congratulations and thank you, both to you as well as Dr. Carl Misch. What he has brought to implant dentistry is profound. And, again, I'm fortunate to having been able to see him educate and then you continue on. You've been the director of his institute for a number of years before his passing and able to kind of have continuity with it to, continue on with the Resnik Institute. So we'll look forward to seeing the prosthodontic textbook. And prosthodontics actually is almost a bit of a hidden, there's not a lot there in the industry. We talk a lot about implant education, but a lot of it is surgically driven. And the question, it's surprising and disappointing that there hasn't been more prosthodontic programs. It's great that your prosthodontic, you have. Well, why don't we go ahead, let you kind of talk through the different types of programs from the Resnik Institute, and we'll finalize the conversation with talking about the virtual program that you're about to launch through CE Zoom. But you have surgical courses, you have prosthodontic courses, you have complications courses. Talk about how those go. We've mentioned it through the discussion, and the prosthodontic courses, I believe, sell out very quickly.
Yeah, so our main course for years has been the surgical continuum. Over the years, I've added so much material that we can't even talk about prosthetics at those weekends. So we started what we call prosthetic boot camp. We usually do it twice a year, and a lot of it is hands-on. From impression taking to digital, you name it, we do it. In fact, we just had one in Dallas last month, and doctors were able to stain PMMAs. So not only did they print a PMMA, then they stained it and learned how to do that.
Wow.
So there's a lot to, and like you said, there's very little out there in the prosthetic, and that's the most important because aesthetics is so important anymore. Patients are so demanding on the aesthetics. So we have the surgery, the prosthetic continuum. Also, probably one of the longest going courses I've had is a radiology or a CBCT boot camp. And basically that's 1 to 2 days of just complete CBCT information from learning the normal anatomy, abnormal anatomy, pathology, and then integrating that into using for surgical guides, all on X, immediate load cases similar to that. We also have a digital weekend where it's a course just for the latest and greatest in digital, and it changes so much. One aspect of our courses is I've never, and Andrew, you can probably vouch for this, I've never given the same lecture twice. I always update it, even if it's only a couple months apart, because things change. And there might be a question from the audience, and I said, that I need to add that to the lecture, which I do for the next time. So also, we've just started a new course, and this is going to be for lab technicians. It's going to be basically an all-on-X for lab technicians because these conversions and the immediate loading prostheses, a lot of these lab techs need to know the prosthetic principles behind it. And a lot of doctors rely on their lab tech to do this. So that's something that's going to be new for next year. And our course, our most famous course is our complication course. And what I've done with the complication course, because there's so much information, I've made it into two different courses. One is a surgical course. That's in February of this year, 2024. And then we're going to give a prosthetic complication course for the first time, which is going to involve not only implant prosthetics, but conventional prosthetics. So Gordon Christensen will be there. He'll talk more on the conventional prosthetics. I'll talk more on the implant prosthetics. So we encompass all aspects of implant dentistry, and we're pretty busy.
I love the things that stand out to me, and I have been around your institute for well over a decade, for 15 plus years. Yes, it continues. Every single course is new and exciting and always has great content. I see it kind of boiling down to a couple things that I always love. Of course, didactic knowledge. You know, you're giving content. There's some that now they do as pre-work because there's so much that you have to fit into a weekend, a multi-step course. The hands-on is always amazing. What you have done to evolve the hands-on techniques, the laboratory sessions, the things that you've done with pig jaws, with, you know, I won't even call them typodonts because you have created such real replicas of what an individual is going to go through, how to use the different components. So the labs and the hands-on portions, you have the live patient portions. But I would argue to say that what I get the most out of is almost at the end of every single program, you do a case planning session.
Yeah. So it's very good. What I like about the case presentation is doctors get to see what other doctors are experiencing, what their thoughts are. And then we come up with a treatment plan all as a group. So the most important aspect of implant dentistry is treatment planning. You have to treatment plan it correctly. And it becomes very easy. And I know, Andrew, I can send you a CT scan today and you can take one look at it and you know what the treatment plan is. And
because we've done so many.
Learn that very easy. It's just repetition.
And it's a way to apply everything that you're taking from, whether it's the pre-learning, the textbooks, the didactic, the hands-on, it's putting it into action and virtually creating these cases. So I love those. Let's kind of round out and talk about the virtual program that you're about to launch. And there's going to be multiple sessions. Talk a little bit about what you've put together for the individuals that will participate. There's case planning portions of it that are going to be interactive and live. So help the audience know what they're going to experience when they sign up for this.
Yeah, so we're going to do 4 programs, and basically we're going to start out just like what we do at the Institute. Start at the basics, work our way up. So we're going to first start with the atraumatic extraction, socket grafting, then go to single implants, multiple implants, full arch, immediate load. And in every one of these sessions, we're going to have case presentations. So I will give a lecture. I will pack a lot of information in a very short period of time. It'll be more of an overview on these topics. And then what we'll do is we'll integrate that information into actual case planning. So we will have a CBCT company that will actually orchestrate the CT scans, and we'll look through the patient's anatomy. We'll treatment plan it, not only with the doctor who it's their case, but also other doctors who will be on the call. So it's going to be a great experience for people. It'll be 4 sessions, and we'll start the basics and end at the most difficult or the most extensive type of treatment.
Awesome. All right. Well, I think we covered a lot. I appreciate you spending the morning with me, kind of going through curriculums, education, but a lot in implant dentistry. There's a lot more that we can talk about. I think that individuals that are going to sign up for that, it's going to do more than just be foundational. They're going to get a lot out of that program. I do think that, anybody should not just take things virtually, but kind of get into the hands-on, the touch, the feel, work with faculty that can be over their shoulder. So I think that kind of progressing from there into an institute would be essential. But what they'll get out of this virtual program, I'm really pumped to be a part of it and participate with you. So thank you. Love the conversation. Always love spending time together, and look forward to next steps.
Thank you, Andrew. Take care.
All right.